Welcome everyone, some of you whose faces I know and some of you whose faces I don't. My name is Joss Young, I'm CEO of RPH Research Foundation, and I'm delighted to invite you to a very COVID-safe Perth City Library this afternoon for yet another in our Public Health Talk series. I am heavily invested in this afternoon's presentation as the mother of a 17-year-old daughter who's about to finish Year 12, and I'm sure some of you are in a similar position. So I'm delighted to welcome our three speakers from Royal Perth Hospital this afternoon. Not only are they clinical experts in their own right, but they're also esteemed researchers, and we're incredibly lucky to have them here this afternoon to take a break from their work, to share with us their stories, their learnings from academia and research, and quite possibly their own research as well. And this is research that takes place over many, many years and gets us to a point now where we can deliver the highest standard of clinical care to the patients of Royal Perth Hospital and the City of Perth. So we've got three speakers, Dr. Jess Soderstrom, who's a toxicologist, Professor Daniel Fatovich, an emergency medicine physician, and Dr. Jenny McCloskey, who is a sexual health expert. So without further ado, I am going to invite, and I'm just thinking I think Professor Fatovich is up first. So Professor Fatovich, UWA Professor, Emergency Medicine, Director of the Centre for Emergency Medicine at the Harry Perkins Institute, and one of our board members, Foundation board members, and welcome Daniel. Thank you.
Okay, thanks very much Joss, and thank you very much everyone for your interest in this important subject, and to everybody who's watching on Facebook. And this is actually a subject that is rated of high importance and of high concern and interest by the Australian community. So just to give you an example, these are some drugs from a patient I saw a couple of years ago who was unconscious, and he'd obviously planned a big night out. So that's some marijuana, that's some cocaine, that's an Ecstasy capsule. This is methamphetamine, ice, and this one was a Viagra-like drug. So as I say, he was planning a big night out and was not intending to come to the emergency department. And this is from a thank you card that Jess, who you'll hear from later, got. It was a thank you card. And it sort of gives the impression that recreational drugs are a bit of a fun thing, bit of a laugh, bit of fun, and I'm sure it is actually for a lot of people, because I don't think anybody would deliberately choose to have a bad experience. But from the emergency department point of view, we only ever see the harms. I've never seen anybody come to the emergency department in my several decades career that said, I've come to the emergency department because I feel fantastic. All right, people only ever come to us because of the harms. And it's just worth reminding people that there is a spectrum of drug use, which you can see in this diagram. And we see people at every part of that spectrum, but obviously in that group, frequent and problematic use is a particularly prominent group. And this is a famous photo taken in our emergency department. It actually won a photojournalism award. And you can see the intense focus of the team members, their eyes on the patient, trying to get them under control so that they can be sedated. And this is obviously an extreme example, but unfortunately it's pretty much a daily occurrence, and that's a really big deal. But everybody's intensely focused on the patients. And I always want to give a special shout out to our security staff, who are, in my opinion, the unsung heroes of dealing with these situations, because they allow us safe access to the patient. So let's start on some drugs. And look, I can't cover all the drugs there are. I'm just going to go through some of the main ones. And so the first one that everybody wants to know about is ice, or methamphetamine, and you can see why it's called ice, because it looks like crystals of ice. But depending on the way it's cooked, the way it's produced, it can look like other formulations as well. And ice can be injected, it can be eaten, it can be snorted, it can be inhaled, and it has really profound effects on the body. And I'm not going to go into the clinical effects because I haven't got time today. So I'm just giving you an overview of the drugs and how much they cost. So, for example, when you walk out of this building and you look along the streets, every now and then you'll see one of these plastic snap lock bags, the little ones. And that's how the drugs are dealt in. They're dealt in points. So 1 point is 1/10 of a gram, all right? And that's from one of our patients. That's basically a point of meth, 1/10 of a gram. And look, for most of the last few years, the cost for 1 point is about $100. But the price varies according to availability. So when it's very available, the price goes down. And I'm told that pre-COVID, the price had dropped down to as low as $30 to $40 a point, which is really, really cheap. It has gone back up now in COVID to about $100, $150 a point, because the supply is obviously a bit harder now. And just a reminder that methamphetamine affects every organ system in the body in very adverse ways. Probably a lot of people have watched the show Breaking Bad. I put this up because in 2007 I went to a talk given by a police officer on how to make meth. And I came away with two main messages. The first one was, that's pretty easy, I reckon I could do that. And the second one was that for a $30 investment in materials, you could get a $500 return. So you can see why there's a financial driver and why serious and organised crime gets involved in this, because the financial returns are so massive. So about 10 years ago, we did a MRI brain study on patients who came into the emergency department having used meth. And I haven't got time to go into the details, but our theory was, do the patients have lesions in their brain that neither they nor the doctors looking after them suspect? And we found that 20% of them had an unsuspected lesion, which was really surprising. And you can see the arrow there. It doesn't look very impressive, that little white dot there. But that little white dot is actually an area of scarring of brain tissue due to the death of brain cells. And this particular person, who's a youngish person, had several of these in his brain. Same again, there's no arrow on this one because this is pretty big and easy to see. Again, an area of scarring of the brain from the death of brain cells in a young person. Now, many of you would have seen something like this, sort of a public health message like this, which is saying that using meth ages you on the outside quite rapidly. But our research, which aligns with other research, is not only are you aging on the outside, you're also aging on the inside. So it's quite natural to, when you're older, of my age, to have those lesions because of age, but young people shouldn't have those lesions. All right, ecstasy. What does ecstasy look like? I'll show you some pictures in a moment, but last year for Christmas I was given this really good book, Fentanyl Inc., by journalist Ben Westhoff, who wrote all about the drug trade. And interestingly, I was reading this book and I learnt about Wuhan. Wuhan is a centre of excellence in China for producing illegal drugs. And then the next week I hear about Wuhan from the pandemic. It was one of those spooky coincidences. So ecstasy was really big in the late 90s and the 2000s, and the chemical is MDMA. And to make it, you need a substance called saffrole, and that is obtained from harvesting the sassafras tree. And there's some pictures of sassafras trees and the leaves. Now, in some Southeast Asian countries, it set off a scramble to harvest those trees. And in Cambodia, there's a very rare type of sassafras tree that produces a huge output of sassafras oil. So to harvest the trees, they have to be chopped down and boiled in these giant vats for a week. And you get about $200 a gallon. And some of those, and for $200 a gallon, 1 gallon makes 1,000 tablets of ecstasy. And some of the law enforcement seizures were seizing 50 tonnes of sassafras oil. So you can see why ecstasy, like there was just millions and millions of tablets of ecstasy circulating around the world. Unfortunately, it causes massive environmental damage to harvest these trees and kills wildlife. And there was a risk of these trees becoming extinct. So some of those countries introduced very heavy restrictions on harvesting of these trees. So that, together with the massive law enforcement seizures, led to a really big drop in the availability of ecstasy and led to producers using lots of adulterated substances. And that's probably the reason, or main contributing factor, or a major contributing factor to the spike in music festival deaths when people think they're taking ecstasy. It's really interesting. There's thousands and thousands of different types of ecstasy, but this is just one picture of them. Typically, it's embossed with some kind of icon. So you can see this one here, that's the Toyota icon. Oh, what a feeling, for example. For a while there was a particular type of ecstasy, the blue dolphin, that was very popular because everybody loves dolphins. Or it's the power of marketing and language. Everybody loves dolphins, and dolphins are these beautiful creatures. So the blue dolphin ecstasy pill must be a particularly beautiful experience, but it's just marketing. Ecstasy pills, look, it all depends on availability, but you're probably going to pay $25 to $50 for an ecstasy pill. And being a stimulant, it really dilates the pupils. And but I always tell people that there are other causes of dilated pupils. So my family tell me that whenever I get a big bill, my pupils go like that. So there are other causes of big pupils besides ecstasy. And so this MRI brain study we did, this was a young woman who came to us about 12 hours after taking an ecstasy and had a seizure. And you can see that this part of the brain here is sort of white and bright and swollen compared with the corresponding part on the other side. This is the hippocampus part of the brain. The hippocampus is very important for memory and learning, and not surprisingly, this person later reported problems with her short-term memory. And the repeat scan at 3 months' time, you'll have to trust me on this, it shows that it's smaller, it's shrunken a bit. And basically, the bigger your hippocampus, the better in terms of your memory and learning. All right, more drugs. Heroin. Heroin is also dealt in points. So remember, 1 point is 1/10 of a gram. And the most typical price for heroin in Perth is about $100 for a point of heroin. And being a depressant drug, it actually constricts the pupil, and that's one of the signs we look out for. Marijuana is the most commonly used illicit drug in Australia, and you can buy an ounce for about $350, or you can get a small starter pack which will give you a few joints for about $25. Again, researchers seem to find that there are structural brain changes associated with the use of marijuana, more specifically the amygdala part of the brain, which is to do with the emotional regulation. For a while there, we were seeing lots of synthetic cannabis. A popular one was chronic. You can see that's a 3-gram tin of chronic, which would cost the best part of $100. And we hated the synthetic cannabinoids because they caused us lots and lots of clinical problems, actually much more severe than regular marijuana. Cocaine. Users regularly tell me that the cocaine in Perth is terrible and it's really expensive. So in the UK, if you're going to have a good night out and you wanted to buy some cocaine, it would cost you about £50 and you'd have a good night out. For a similar quantity in Perth, possibly of lower quality, you'd be paying hundreds of dollars, $400 to $600, which is quite a lot of money. But in more recent times, the price of cocaine in Perth does seem to be heading downwards, and which then increases use. And I can say from my experience that in the last few years, I've started seeing more cocaine-related problems than I ever have before. All right, LSD. So LSD is typically sold in these little tabs, almost like smaller than a stamp-sized tab on blotting paper that you put under your tongue. And they're typically beautifully artistic pieces of work. My favourite one is Donald Duck, because I was always a big Bugs Bunny fan when I was a kid. There's another one here of Albert Hofmann, who was the inventor of this, and who used LSD, and remarkably, I learnt recently, lived to be 104 years old. So these little tabs of LSD cost, and again, it varies according to availability, but you might pay $25 to $30 for one of these tabs. And finally, this is the last illicit drug that I'm going to go over, is GHB, often known as liquid fantasy. This is a drug that people take because it's stimulating and causes a bit of a high, a bit of a euphoria, and is said to be an aphrodisiac as well, hence its popularity. The dosing window is like really narrow, so it's really easy to get the dose wrong. And when you get the dose wrong, basically you end up in a coma and have all sorts of problems. A 30 ml container of GHB might only cost you $30. It's pretty cheap, but you can never trust the dosing. One of the things that we've noticed is since COVID started, there's been a big spike in people we're seeing with GHB overdose. And the last drug that I'm going to mention is a legal drug. Nitrous oxide, or laughing gas, is often sold in these little cylinders. The nangs is what they're called, to help you whip your cream. And there's 24-hour services to have boxes of 100 of these nangs delivered to your door for that 2 a.m. cake emergency. In fact, one of the sites I think is 24-hour cake emergency, Uber Nang, Nangaroos, and it costs about $1 each, even cheaper. But the thing is that we're finding is, although it's popular with young people because it gives them a bit of a high, some people are using literally hundreds of these per day. Hundreds per day. And unfortunately, it has a very serious harmful effect in that it causes degeneration of the spinal cord. So you've got these young people, and we're seeing them now, who've got degeneration of their spinal cord and can't walk properly or have abnormal sensation. And it can be permanent, it can be irreversible. Luckily for some people it's reversible with treatment, but there's no guarantees. So that's a very quick tour of some of the recreational drugs around town. I always tell people that working in the emergency department is a bit of a window on the world, and we'll see what else we see today. But just another figure for you, 7% of all the patients that we see in the emergency department at Royal Perth Hospital are related to illicit drug presentations. Thank you.
Thank you, Daniel. We're going to hold our questions till the end when all the speakers can contribute to the dialogue. When you see it all laid out like that in front of you, it really is quite profound and scary, and it makes me feel incredibly naive. So thank you for sharing what must be an extremely confronting experience day in, day out. Okay, our next speaker is Associate Professor Jenny McCloskey. I've heard some of Jenny's stories before. They never cease to amaze me. So I'm going to invite Jenny, our Royal Perth Hospital resident sexual health expert, to share her stories with you. Thanks, Jenny.
Thank you for inviting me. All I can say is the door of the emergency department leads to the door of the sexual health clinic. And our patients love all the drugs that they use in the emergency department, and like that first slide of Danny's, they like to use them all at once and to gain a continuous erection that lasts for days on end if they possibly can, and then they come and see me. But many of you may have never have met a sexual health physician before, and so I thought I'd just talk to you a bit about. I was talking to one of the anaesthetists at Royal Perth Hospital quite some years ago, and I was talking to him about my pet galah, who was called Einstein, and he said, "Jenny, that's what a sexual health physician is, someone who looks after a cockatoo." So here you are. This is my work described in form, and it's part of my work. But in all the years I've worked in sexual health now, all I can say is we've never seen so many STIs. The STI rates in Perth now are the highest we've ever seen for every single STI, and I'm going to go through some of these with you to just share with you. Perth is not Dullsville. It's certainly a very interesting city. So this is just data on the number of chlamydia notifications, showing that, in fact, chlamydia, when I started, it would have been down here, but now it's just continually present with more women diagnosed than men. We think that's because women have regular pap smears. Whether that'll fall off now with the screening program, I don't know. And there actually is a little bit of good news about chlamydia. But before that, I just want to show you that the chlamydia is commonest in the younger age groups and more common in women than men in that younger age group. But as the age group gets older, it's more common in men. So we think that's transmission amongst the gay sexual population is where this more common in the men is occurring there. And this is the good news about chlamydia. Amongst that very high rates in the age group, we can actually see now that the proportion of chlamydia in this age group as a total of the whole chlamydia rates is actually falling in that young age group. So something is happening. I'm not sure why that's happening, but that is good. So less in that very vulnerable age group is a good thing to be seeing. So there's some progress being made in one group. Now, I once spoke to one of my colleagues and said, I'm going to be talking about chlamydia, and this is just to remind you of what this colleague's definition of sexual intercourse was. So he says, sexual intercourse is polyorificial, polymicrobial recirculation. And this is just to remind you that you might be horrified by what's actually happening, and that would be the 69 position there. This is oral syphilis, and we see a lot of young people these days who just do oral sex who get the herpes from the mouth transmitted to the genitals, and they may not have actually had insertive sexual intercourse at all, but they actually get herpes for the first time on their genitals just by kissing. And half of the genital herpes these days is actually due to type 1, the oral herpes going to the genital region. So chlamydia, koalas do get chlamydia. So they, in women, it can cause a discharge, and in men, it's asymptomatic, but in men, they can get a discharge or pain passing urine, And when I was doing this talk on koalas or chlamydia, my same colleague that described sex as polyorificial, polymicrobial recirculation, he said, "Jenny, I think koalas have 7 vaginas." And I said, "What?" And I thought, well, because I'm talking to doctors, I better go and check my facts. So I actually went to rang the Murdoch Veterinary School and spoke to the lady at reception there, and she said, "Well, I'll put you through to our veterinary department." And I said, "I want to find out how many vaginas a koala has." This is a true story. I actually did do this. And she put me through to this vet, and he says, "I don't know, but I'll contact one of my colleagues over in Queensland to find out." And because I thought, I've got to find out actually how many. So in actual real truth, this is from a bit of paper that I got sent from this veterinary person at Murdoch, from his colleague in Queensland. Koalas, female koalas actually have 3 vaginas. So I think koalas should be called Wonder Woman, and I think we should have koalas on the Australian flag for sure. And the koala anatomy is quite extraordinary. So this is just to show you. So female koalas have one hole that everything gets done in and out of. So this is urine, faeces, but then up here they actually have 3 vaginas. They have a lateral vagina and another lateral vagina and a median vagina. And apparently the middle vagina actually gets closed off after the birth of the first koala. So I just think this is pretty amazing. So, but what about the male? You thought about what? So I've got another picture sent to me, and here is the male koala. He has a penis that's half split in 2, so obviously he can fertilise either of the 2 uteruses that actually exist. So, but when you get into the sexual things with the wild kingdoms, then there's apparently a lot of good stories to be found. So koalas have chlamydia, humans have chlamydia. What actually causes chlamydia worse in koalas and causes problem is stress in their population. So bushfires stress koalas, but the other thing that stress koalas is crossing roads and being chased by dogs, and that stresses them and makes chlamydia more a problem in those communities. And Kangaroo Island was chlamydia free, and they're not allowed to take the chlamydia free koalas and put them in other parts of Australia. They don't like to do that because they think that's wrong. So chlamydia is easily treated in humans if it's diagnosed. And I mentioned that Perth's not Dolesville. Look at what's happening to gonorrhea. It's just going up and up and up, with more gonorrhea in men than in women. And we forget that as the rates go up, we forget about what actually happens to the mothers who are pregnant. So there's a lot of things happening now where we're concerned about. And gonorrhea in infants can actually cause blindness. So the first day on the planet, the little baby goes blind because mother's got gonorrhea. We forget about that. We think that we're just dealing with adults, but we need to screen, we need to recognise that it's increasing, and people need to have tests. And this is one of the microscopy pictures here showing the intracellular, the bacteria inside a cell that make us recognise gonorrhea, but we do other testing as well. And again, this is showing that the gonorrhea is particularly high, again, in that young age group. But in these figures, it's showing it's more common in men or more picked up in men, and we think that's because the men have symptoms. So, it hurts, or you notice a bit of pus or a stain on your underpants, so we think that's why it's picked up. And then what happened in COVID? We actually found, this is data recently produced by the Health Department, and I'd like to thank them. This is showing that the chlamydia rates and syphilis rates actually went down in COVID, But I actually don't believe it was less sex. My grassroots information is people were having a lot of sex, and I don't think that all our patients were isolating. And I wonder, in fact, whether the amount of testing might have gone down instead to actually, and here you can see that the gonorrhea rates didn't change at all. So again, not sure why, but there's something that doesn't make sense there. But I don't believe our patients were self-isolating. They kept ringing our clinic to come and be tested. Now this is my jaws picture. This is a pubic louse, and there's actually a book, which unfortunately I don't have, called Life on the Pubic Mound. So if anyone's got a copy of that, I want to get a copy of that. And this is just showing you the pubic louse, and these are really rare. Our patients used to cut them off and bring them in jars for us, and we used to put them under the microscope. It was amazing. You'd see their heart beating. But what I wanted to show you here is this, it has a fixed pincer grip. So that's why you don't see people with all their pubic lice all over their eyebrows or on their hair, because their grip is fixed for pubic hair, which is thicker than the hair on your head. So the crabs actually fall off. And these days people are going Brazilian, but one thing that I've learned recently is if you're a bike rider, serious bike rider, don't do Brazilian, because the pubic hair stops you getting saddle sores. So just so that you know, the Olympic teams, you get protected from your saddle sores by keeping your pubic hairs. Now, people say, oh, Candida, and lots of women now just go to the chemist and buy their own Candida treatment. And I've put this up here because we're now starting to see the emergence of drug-resistant Candida. We thought that would happen. Really serious issues now. So this is a common and garden variety 1, and these are all the drug-resistant types that are now occurring. And I had a tragic moment in my practice last week with a woman I was treating for Candida. She came into me really distressed, and these days you can do your own testing. So we give people these kits, and I'd given this female one of these kits, but here she was in my practice and she hadn't done it. And she's saying, "Doctor, can you please do my test?" And I say, "Why? I gave you a kit." And she said, "The dog ate my vaginal swab kit." So it's got a plastic case in here, a bit of paper, it's all in plastic. So now I have to say, well, when I hand these out, don't give these to wild animals. Not for use by wild animals. So, she said the dog was fine. But so I wait to hear. It's a tragic story. Now this is to tell you the health department now has released an alert that there is currently an outbreak of syphilis in metropolitan Perth. So it's huge numbers. All the GPs in Perth have been notified, and it's rising, and we've now had at least 2 stillbirths in women who've had syphilis in pregnancy, and the babies are now affected. So all I can say is for people like Danny, please test as many people for syphilis in your department, because it's a very, very serious problem at the moment. And it's caused by an organism, Treponema pallidum, which is a spirochete. There you can see. We used to like getting the microscope out and looking at it in our lab, but these days that art's gone. And the other thing is, apart from being a doctor who looks after a cockatoo, the thing that I get in my job is people always give me things that look like penises or pictures of things that look like penises. And this was taken by one of the secretaries at Royal Perth. She was a really interested photographer, and she won a prize for these. These were toadstools growing in her backyard. But this is to just highlight the point that when we find one STD, we always look for others because they travel together. And we would say that about 2 out of 5 patients have a second STI. So that's why we screen for everything. And syphilis and HIV often occur together. So this is just to say what I've said is syphilis is back in Perth. Mother Superior, we've got a case of syphilis in the convent. Oh, thank goodness. I'm sick of the Beaujolais, yes. We thought we had a handle on HIV, but it's going back up again. There's an amazing drug now that people can take to stop catching HIV, 1 tablet a day. And that's the way as medical practitioners we encourage people to have it. But there is a shortened version of that where people hop on and off it. We don't think that's quite so safe. But a lot of this increase is, so we're seeing a decrease amongst gay men, but there's more HIV now occurring in heterosexuals. And just to share with you some of my research, you saw some of Danny's case reports, but I actually did a PhD on anal cancer. My mother asked me, she's 97, isolated in Melbourne, living alone. Jenny, what was your PhD on? And I said, I'll tell you later, Mum, but all I can say is she's proud of what I do. So, I actually have an interest in human papillomavirus, and so I've been excising warts in theatre for quite a long time, and we put all of these warts into, we keep all the material, the hospital never throws warts out, and we've now created a biobank and we can do research from that. But this is just showing you that anal cancer is a really rare disease, but it's increasing in men and women, and at the moment the rates are higher in women than men. And I have these women who are 70 years old, 80 years old, being referred to a sexual health clinic, just morbidly embarrassed that they're coming to a sexual health clinic and why, but I'm able to work with the colorectal surgeons and people to follow them up. But there's been an extraordinary bit of research done out of Tasmania where they talked about the wiping practices. So before we got HPV vaccine, women and men, probably 80% would have caught some sort of human papillomavirus. And we think what the research out of Tasmania showed is that the women that wiped from front to back had more HPV in their anal canal than the women who just dabbed. So we think it's the wiping practices of women and not sexual anal sex that's causing the virus to get into the anal canal. So we need to let that message get out so that more women can be diagnosed and not be so embarrassed about the diagnosis that they actually have. But we were interested because of the pre-cancer we're finding in warts to look at other things that might actually be happening. And so we were looking at how if you had high-risk HPV, a cancer strain of HPV in warts, what else might be a driver for the development of high-grade abnormalities and ultimately cancer. And this work was done with Michael Phillips here sitting in the audience. And so we found that an epidemic of STIs is driving this. So, and we've actually found an association for all the STIs we're able to study. So genital herpes, chlamydia. We know that chlamydia increases HPV replication. So the more times the virus multiplies and causes cells to multiply, the more likely you get a precancerous change. We think that gonorrhea increases the risk, and syphilis and HIV, hepatitis B and C. So they're all driving an increase in anal cancer precursors. And so from the work that I'm doing with Michael is I actually think we're going to see more anal cancer, particularly amongst men. So the thing is, though, that the men who have sex with men have learned that they can take this 1 tablet a day and stop catching HIV. And what's that's translated to in the general population means, are you on PrEP? Okay, condoms off. So they're not worried about the gonorrhea or the syphilis or the chlamydia. They're just great pleased that they can stop catching HIV. So the rates of gonorrhea and chlamydia and syphilis are going up, but the HIV is lessening. So we've got a real problem. And again, huge issues with sexual inhibition with drugs. So Danny sees them, we see them in our clinic as well. And the other thing is we think that people now just meet online. They often go to a hotel room to meet. So that our contact tracing is not so good because we are not able to find the people that they've actually had sex with. Often it's anonymous sex. Sometimes we actually have people come in who've had sex with someone, and it seems to be the thing they do is while the other person's having the shower, they actually go through their bag and they find the HIV medication. So these days people aren't telling them that they're infected with HIV. But what we do know is if your viral load is undetectable with HIV, we think it's not actually being transmitted. And so this medication now is fantastic. So we're encouraging all the people at risk of acquiring HIV to be on that medication. But again, for me, the issue is I've said, the gonorrhea and the chlamydia, this is all contributing to another problem down the track. How do I get the people to start using condoms again? It's not the fashion, a real issue for me as a clinician. And I just wanted to end up by just talking to you a little bit about the HPV vaccine, because this was designed out of Queensland and they're currently working on a COVID vaccine. Ian Fraser up there was involved with this, and this is thought to be one of the best vaccines that has ever been designed and made. So what they did is they were able to make a little bit of the shell of the a shell of the virus, and then they made enough of them, and when they made enough of them, they actually found it made a whole outer cover of the virus. So the real virus has got this nucleus, but the vaccine has got no nucleus, so it's no live virus in it at all, but the body thinks this is a real McCoy, and it makes really high antibody levels that really protect. So at the moment we've got a vaccine that has 9 types of HPV in it, and luckily in Australia our government is rolling that vaccine out to the boys and girls at school. And all I'd say is that it's a fantastic vaccine. We think not only does it reduce the risk, we know it reduces the rates of abnormality on the cervix. Warts are virtually dinosaur disease now. We think it's going to reduce the rate of anal cancer, but probably not for 40 or 50 years, and we think it's going to reduce the rate of oropharyngeal cancer. So it's a vaccine that I'd really make sure that if you've got children going to school, or if you've got children who've missed out, I'd recommend that they get the vaccine. So I'd like to end up by saying that even though we have these wonderful tablets, we have the vaccines, I recommend that still people use condoms. And just because of my interest in warts, I've always been fascinated that they actually have condoms designed for people with warts. So thank you very much.
Thank you, Jenny. I did say she had wonderful stories. And to finish up for our third presentation today, Dr. Jess Soderstrom, toxicologist. Jess will bring the speaking sessions to a close, and then we'll open the floor to any questions. Thanks, Jess.
So we've had drugs, we've had sex, and now we've got rock and roll. The glitz and glamour of rock and roll is a far cry from my workplace. Can I introduce you to our corridor in our emergency department in Royal Perth? I also call it a corridor of misery. This peaceful image of people just walking around, minding their own business, belies the fact that only a few moments ago, a patient was brought in by paramedics and police. This man is brought in. We have all these big posters in our ED with our esteemed leaders encouraging you to wash your hands. He looked at the poster. He was staring it at the eyes. He starts taking a flying crane stance and then jumps and leaps and kicks it. He was convinced that the poster was attacking him. In that little nook in that corridor, we had another guy who was convinced, who has just been brought in at the local service station. He was sitting there throwing credit cards around. He was convinced that the magnetic strips on the credit cards were reading his mind. While all of this was happening, I had a tap from our triage nurse saying, by the way, there is a lady in the back of a paddy wagon, terrified, cowering, worried that she's been fishing dead bodies out of the Swan River. These are stories of drug-induced psychosis, most commonly caused by methamphetamines. In each of these cubicles are sedated patients with the nurse looking after them. In 2019, we saw about 75,000 patients come through our ED, of which 7% are drug-related. In that time, about 8 patients a day would come in with methamphetamine-related complications. This year, with COVID, the number of presentations to our ED dropped by about 30%. However, the number of patients coming in with methamphetamine-related complications, we still saw about 7 a day. Drug-induced psychosis is common, especially with methamphetamines, with 77% of our patients coming in with some form of psychosis. 90% of them need some form of sedation. And you've seen this image before. It will give you an idea. This is one of 8 patients coming in per day needing to be sedated. It gives you an idea of the amount of resources that actually needed to look after one of these patients. The impact on the ED and on the staff cannot be underestimated. You will see here, I have one of my registrars who's just minding his own business. This happens on a regular basis in our ED. There is a level of violence that we deal with on a day-to-day basis in our ED. We had a snapshot in the ED. And in 1 week, we basically counted how many times our staff were getting attacked, how many incidences of violence were they coming up against. In that week, we saw about 1,400 patients. In that 1 week, 543 of our staff members had recorded 543 incidences of violence. Most of them was verbal. More than half of them were verbal abuse. 26% had intimidating behaviour, people just coming up to you and being threatening, and 5% of actual assaults. This is in 1 week. Until recently, when people came in with illicit drug poisoning, we would have no idea what it is that they've taken. We would simply treat them symptomatically. We have been working with a chem centre to determine a method of blood collection, first of all to work out what it is that was causing people to be unwell, and also if it was a useful exercise. So one of the reasons why it's very, very difficult to differentiate when people come in with illicit drug poisoning, why it's difficult to differentiate what's causing their poisoning. Let me give you some idea. Let me explain why. So if we look at this basic structure, that's a phenylethylamine. You will see this in adrenaline. Now, we all know the effects of adrenaline on the body. As I'm standing here, stumbling over my words, I'm anxious, my heart is racing, and I can tell you my pupils are big. Now, you will see in the next few images that this structure is also seen on our stimulant drugs, in methamphetamines, in ecstasy. This is N-bomb, which is synthetic LSD. So it explains why when people come in with illicit drug poisonings, they look so similar. So why is it important that we work out what it is that people have taken? What does it matter? I mean, why change what we've been doing all of this time? Just treat them symptomatically. So we've been running a project at Royal Perth Hospital called the WISE Project, the WA Illicit Substance Evaluation Project, for the last few years. And we have learnt a number of lessons from it. Often what people think they have taken is not what they have taken. So there was a cluster of patients that came in from Vic Park who had bought in what they thought was cocaine. They had 9 lines and they all snorted it, and they came in various forms of delirium. They were agitated, they were hot, they were sick, they were profoundly unwell, and they were distributed all around the hospitals in Perth. What we worked out was that, in fact, what these patients had thought they had taken cocaine, they were completely dudded. It was actually hyoscine, which is a travel sickness tablet. Now, normally, if people take travel sickness tablets, it's like, it really doesn't cause much of a problem. However, if you are to snort it and take it in big quantities, the clinical picture becomes really quite messy. They can come in looking very much like amphetamine toxicity. Now, this really sort of started the ball rolling in terms of realizing how important it was to actually know what agent it is, because what it looks like clinically is often not what is actually the case. And it actually does change what you do. It also indicated to us, it was actually quite important to work it was also very important for us to store the blood properly. Because patients went to the different hospitals, and we managed to get all of those samples from the different hospitals collected and sent to the chemistry center for analysis. When in the other hospitals where we did not have the standardized method of collection, the levels in those blood samples were much lower than what we found when you had a proper system of doing so. We also, in 2016, in Christmas 2016, in one hospital we had 16 patients that came in profoundly unwell after having taken what they thought was ecstasy. We're talking here young people who are not regular drug users, who are just at a party having just taken what they thought were ease. And on Christmas Day, there they were, we had so many patients come in so unwell. We had patients in the ED on ventilators because they had taken what they thought was bad MDMA. Now, what we did was that some of their friends did the right thing, came in, brought in the tablets saying, this is what my friend has taken. That, together with their blood analysis, we worked out that what was being sold as ecstasy was in fact a combination of N-bomb and 5-fluoroamphetamine. That's a synthetic LSD and amphetamines. Now, this combination of drugs was really quite dangerous. What we also realized in that year is that all these media reports out there of all these different deaths around the country, reporting on bad ecstasy, that all turned out to be this new agent. So we worked with the police and put out a public health message around, be aware of this particular capsule. We haven't seen it since. And this really demonstrated the importance of trying to work out a better, more systematic system of putting out warnings, of developing an early warning system where we can notify frontline workers to work out what it is that they have taken, as well as working out a way of putting out public health messages. The lessons around methamphetamines. I've told you the stories around the drug-induced psychosis. We had initial hypothesis when we first started the study that people came in psychotic because of methamphetamines. We assumed that they would have really high meth levels. But when we looked at it, they didn't. Now, I'm going to make a bad assumption here that if you're driving a car on meth, that you should be okay. Hopefully not psychotic while you're driving a car. What we found in our cohort of patients that came in with methamphetamines, their blood levels were only half of that of roadside testing. Which then begs the question, what's making them psychotic if it's not the high meth levels? We now have to rethink that perhaps it's actually the pattern of use. Perhaps it's the sleep deprivation that is causing their psychosis. And we need to actually look into that to work out why that is. Because the majority of patients will settle after about 11 hours. And we were actually able to quantify for the first time the impact of meth on an ED. Knowing what agents are causing toxicity changes how we manage patients. Again, we had a cluster of MDMA quite recently. And this young lass was brought in having had uncontrollable seizures. And she came in outside a nightclub, as part of this 6 patients that came in from around our local night spots. We had made the assumption that she was a part of this cluster. She must have taken some MDMA. Because she came in as part of a cluster, we could actually turn the bloods around very, very rapidly. And we got the results back within 24 hours. And it turned out that she had no MDMA on board. Now that in itself is very, very important because it changes the direction of our treatment. If it was due to drugs, we managed them a certain way. If there was no drugs on board, we have to then look at other causes of her seizures. So it changes our management. The importance of having accurate information out there is vital, and we have to move away from anecdotes. It actually allows us to have a more targeted approach to public messaging in terms of working out how we get the information out to the frontline workers as well as to the general public, with the main aim to minimize harm. Clearly, mind-altering drugs have been around for many years, but the way we're treating them and managing them is changing. Because it's become quite clear that our standard Band-Aid therapy is inadequate. And it can only be done by having a systematic, collaborative approach to determining what agents are causing harm with the overall aim of minimizing harm. Thank you.